So, good evening, everyone. I'm really delighted to welcome you to the webinar, ERS webinar series, with a great team of panelists composed of Axel Wolf, who is the specialist ENT rhinologist working in Graz, then Vittorio Rampinelli, who works in Brescia, head and neck department, ENT department, and then lastly, Professor Meco, who is, as you all know, president of the Confederation and works in Ankara, but is also affiliated with many other great departments. My name is Pavel Serda. I'm the ENT consultant working at Guy's Hospital in London. And this webinar is brought to you with the great help of Olympus, who are really thankful for. And now I would like Axel to ask for a first talk on hemorrhagic emergencies, which will be followed by Vittorio. His talk will be on orbital complications, and then lastly, Professor Meco will talk about intracranial complications. Axel, please, I give you the word.
Thank you very much, Pavel, for this nice introduction. Just give me a second to share my screen. Perfect. So thank you very much for this introduction. It is a great pleasure being invited for this session tonight and to talk about hemorrhagic complications. My name is Axel Wolf from the ENT department in Graz. And yes, I will just start right on. Thank you for joining the webinar tonight. So my topics will be, I will give a short introduction about hemorrhage, nasal hemorrhage and epistaxis in general. I will focus on the sphenopalatine artery and ethmoidal arteries, and just to mention intraorbital hemorrhage, but there will, after that, Vittorio will take over and you will hear about that more. So epistaxis is a topic that matters. You saw just last year another clinical practice guidelines for epistaxis was published in New England Journal of Medicine, where it was also stated that 60% lifetime prevalence in the general population of the US suffer from epistaxis once in their life. 6% out of them seek for medical assistance. You all know these treatment algorithms. Of course, I will not go into detail about that. You're aware of that. But just to mention, as a rhinologist, we do know that we are mainly at the end of these algorithms in treatment of our difficult cases. On one hand, we do have spontaneous epistaxis. On the other hand, we also do have the surgical complications intra and post-operatively. So these are the main cases on which rhinologists have to work on. Which are the main troublemakers? I mentioned them before. Of course, anterior ethmoidal artery, posterior ethmoidal artery, and sphenopalatine artery going into the nasal cavity. And of course, very often these vessels are responsible for heavy bleeding episodes. In treatment of epistaxis, you all do know that, of course, at first you have to get an overview, especially if you're going to treat epistaxis endoscopically. You have to get rid of all the blood, of all the coagulated blood intranasally. But just to mention at the beginning, it is really important if you think about endoscopic treatment of epistaxis that you control your surgical field. Take your time, use your aspirators, and of course we do use adrenaline to reduce swelling as well as bleeding. We do use adrenaline 1 to 1000 in these swabs, nicely squeezed out. Adrenaline 1 to 5000 or 1 to 10,000 is also fine, used in many other departments, but we have good experience with adrenaline 1 to 1000. So first point, sphenopalatine artery. Sphenopalatine artery and enters the nasal cavity through the sphenopalatine foramen. Here, a look onto the lateral nasal wall. We do have maxillary sinus here and sphenopalatine foramen. In this area, we do have the ethmoidal crest, which can help you in dissecting towards the stalk of the sphenopalatine artery. I will mention that afterwards, but this is the major anatomic orientation. Here, a short video clip of a branch of the sphenopalatine artery bleeding very superficially. In this video clip, we have here the lateral nasal wall. We have here the posterior attachment of the middle turbinate, which is here on the left. And this is also a very important landmark I will mention later on. So if you're going to treat an epistaxis endoscopically, it can happen that you have a branch of the sphenopalatine artery, very superficially, very easy to find. And in few cases, it can be easily coagulated here using a bipolar device, and the problem may be solved. But in many cases, you have to go for the stalk of sphenopalatine artery entering the nasal cavity. And as mentioned before, the posterior attachment of the middle turbinate is a very important clinical landmark, because we do know that approximately 0.5 centimeter anteriorly, inferiorly, or beyond these branches of the sphenopalatine arteries enter the nasal cavity. It is also very important to keep in mind that we can have several, up to 10 branches going into the nasal cavity from the sphenopalatine artery. So if you dissect and find the first branch of the sphenopalatine artery, don't stop there. You have to be sure that you really solve the problem and it's not another stalk that it's bleeding. Here we can see it in a cadaver dissection. Our basic steps in treatment for coagulation of the sphenopalatine artery. Again, here the view onto the lateral nasal wall, posterior attachment of the sphenopalatine artery, and there the mucosa is already incised, and then you can lift a mucoperiosteal flap. You start your incision about 0.5 centimeter before the posterior attachment. You go towards the posterior attachment. Here, the medial wall of the maxillary sinus, the posterior fontanelle. So try not to break into the maxillary sinus, but if you are in your layer, you can easily dissect it. Here you can also see the ethmoidal crest. I don't go and look for it, but it can be a hint that you are going towards the sphenopalatine artery. And here we can also already see 2 branches going into the nasal cavity. Of course, in real life, it's bleeding more. So here another video clip. Additional, you can use local with epinephrine 1 to 200,000 submucosally at the beginning of your dissection of this mucosal flap. There it can help to lift your mucosal flap, which can make dissection, of course, easier. Principle the same in this video clip. So incision here using a cuttle knife, preparation of the mucosal flap, and then go for the sphenopalatine branches. Again, don't stop at the first branch you see. Another branch that is situated more posteriorly can be the source of your bleeding. And then we have different devices. In this case, we used a bipolar forceps. I don't like them that much because they have a pretty long stalk, but can be also used in this case. I will focus on the instruments a little bit later. And after that, after the problem is solved, you can just flip back your mucosal flap. In general, I do avoid non-resorbable packing, because if you did your job well, there will be no further bleeding. So I try to avoid any permanent packing possible at the end of these procedures. Don't forget to look into the inferior meatus. If you're treating an epistaxis patient endoscopically, I saw a few times that this was the mistake, that during procedures, no really bleeder was found. But this is a video clip from the inferior turbinate, lateral nasal wall. So if you don't find a bleeder or in any endoscopic treatment of epistaxis, look underneath the inferior turbinate during your procedure, just checking if there is any bleeder, which can also easily be treated, but don't forget this. This is an important point in my opinion. Another bleeder coming from the sphenopalatine artery, the branch going to the nasal septum. This is the natural ostium of the sphenoid sinus, here enlarged. If you enlarge it directly, it can easily happen that you damage this branch. The bleeding itself, of course, is no problem, but if you're going for a skull base case and you need a nasoseptal, a haddad flap afterwards, take care of your vessels over here in order not to harm the feeding vessels for your leather flap. The anterior ethmoidal artery, you all do know, ophthalmic artery, brings the anterior and posterior ethmoidal arteries into the nasal cavity. And these arteries are going through the nasal cavity back intracranially. And they can go along the skull base, but anterior ethmoidal artery also underneath the skull base. Here, Caros classification is important. The lateral lamella of the cribriform plate, Caros 2 to 3 in combination with a supraorbital recess also always shows that your ethmoidal arteries go through potentially through your operating field. On your CT scans, they can be found easily. You have to look for the medial rectus muscle and the superior oblique muscle, and there you can find in your scan a pyramid-shaped excavation. And in this case, there is an asymmetric anatomy. On the left side, the anterior ethmoidal artery is going underneath the skull base, right side within the skull base. So be aware that in your cases, it can be a different anatomy on both sides. This is a video clip by old Professor Brown. Here we do see the ethmoidal artery damage and bleeding. We see up the way there to the frontal sinus. If you harm the anterior ethmoidal artery, normally it's no problem. You just have to use the right instrumentation. You need angled endoscopes as well as angled bipolar devices. Again, adrenaline. And here it can be a little bit challenging to go around the corner, but mainly it is no problem to solve this bleeding. During fast procedures, don't go to look for the anterior ethmoidal artery, but if you go with it, just be aware if it's going with in the skull base or through your operating field. Mentioned suction devices, again, bipolar suction devices with suction function are very useful. There are many on the market. Just to mention monopolar cautery, on one hand, I do like to use it sometimes for the sphenopalatine artery, but be aware, don't use it at the skull base, especially if you have a skull base defect, because monopolar devices are going through the dura like butter. So if you're working at the skull base or even with a skull base defect, don't use your monopolar devices. Posterior ethmoidal artery is a pretty bad landmark. They are often not nicely seen in CT scans. They are running in the skull base, but you can run through it as well. For example, here another case with a skull base defect at the skull base case, and the vessel itself is nicely exposed over there. And if there is the bleeding from this side, it's also normally no problem to treat it. And again, don't use the monopolar device, especially in this case, where we can see the defect, skull base defect, and yes, be aware of that. That brings me to my last words, acute intraorbital hemorrhage. You will hear about that after that. I mentioned before, ophthalmic artery leaves the anterior aphmoidal artery into the nasal cavity, which enters to intracranially again. And if you then damage it intranasally, you can have the situation with the intranasal bleeding I showed you before. But for example, if the vessel retracts intraorbitally, it can lead to such a situation. And if you see a patient like this, especially post-operatively in the wake-up room, then you have to hurry. You don't have a lot of time. And with these words, I would like to thank you for your attention and give over to our next speaker. Thank you very much.
Pavel, you're muted.
Right. So whoever was not lip reading, then thank you, Axel, for a fantastic presentation. And now I'm going to give a word to Vittorio. Before that, I would like to just encourage the public and the audience, please send us questions via the chat, and then we will try to answer them at the end. So just click on the chat button, type the question, and we will have a look at it in the meantime. Vittorio, please.
So good evening, everybody. Thank you for the invitation. And every rhinology needs to be able to face different orbital scenarios that can be encountered during everyday practice, in particular in terms of orbital complication of rhinosinusitis and orbital complications of endoscopic sinus surgery. So during my presentation, I'm gonna cover these two different topics. Starting with the former, orbital complications of rhinosinusitis can be classified based on the inflammation type and phase. Cellulitis can be defined as the presence of vascularized inflamed soft tissues, and as we will see later, usually is suitable for medical therapy. The abscess can be defined as the presence of a necrotic purulent cavity, which is usually suboptimally reached by medical therapy, and so usually surgery is necessary. And here we have the worst scenario, so thrombophlebitis, which consists in the retrograde diffusion of thrombosis and phlebitis towards venous sinuses, typically the cavernous sinus at the orbital apex. So I want to introduce immediately the Chandes classification, because this classification will guide our presentation. And this classification is based on the type of inflammation process and position of the inflammatory process. So we find 5 incremental stages, from preseptal cellulitis, postseptal cellulitis, superiosteal abscess, intraorbital abscess, and intracranial infection. In the last few years, Chanda revised this classification, removing the preseptal cellulitis and intracranial infection. I'm not going into detail about this revision, but this revision is justified by the needs of better etiological assessment and guidance for the treatment. So talking about the incidence, these complications are not negligible. About 6% of patients with acute rhinosinusitis, with the pediatric population as the most vulnerable age, in particular from 0 to 9 years old. But we don't have to forget older patients also maybe with mild ocular symptoms associated with acute rhinosinusitis, especially in case of immunocompromission or diabetes. Stage usually is associated with the number of the involved sinus and the severity of the clinical presentation, and stage 2 or higher should be suspected in presence of ophthalmoparesis or plagia, proptosis, increased ocular pressure, visual acuity change, and pupillary reflexes alterations. Coming to the practical points, when and which type of imaging? When we suspect the above mentioned symptoms, so important eye symptoms, so another time, proptosis, pain during the absence of movements, ophthalmoparesis, plagia, edema, and visual alteration. These are connected with with a higher probability of stage 2 or higher problems. So we need for a contrast enhanced imaging. Usually CT scan in the emergency setting, it's enough, but of course, if we have MRI, we could have more information. Starting in the deep vision of the different scenarios, preseptal cellulitis, typical of the pediatric population, is usually treated with single or double antibiotic therapy, and especially in the pediatric population, the success rate is very high, around 100%. Orbital cellulitis is associated with the development of orbital and preseptal abscesses, around 40%, so it's a very high probability to evolve in an abscess. Is associated with permanent sequelae, and usually treatment consists in antibiotic therapy associated with steroids, and surgery should be considered in case of visual acuity or motility alterations, another time pupillary reflexes alterations, and extensive eyelid swelling with no visibility in the eye, and suspected high pressure inside the orbital cavity. The subperiosteal abscess can be associated and predicted when the patient has a motility restriction. This is a very nice tip. And in the literature, there's no really clear indication of the optimal treatment zone, when and how to perform medical therapy versus surgical. But usually you can say that the subperiosteal abscess poorly respond to medical therapy. So usually surgery is needed. The orbital abscess is a complex clinical condition with a higher risk of permanent sight or ocular impairment, and we need for urgent surgical drain and antibiotic and steroid therapy. Last but not the least, cavernous sinus thrombosis, very, very severe condition. We need high dose antibiotics, anticoagulation therapy, and of course, early surgical drainage of the infected sinus or mucocele. And this can reduce the mortality and morbidity, which is not around zero because it's a life-threatening clinical condition. But I will leave this topic to Professor Meco. Till now, we have spoken about the treatment in a very generic way. I want to underline this nice article from the group of Graz. And I'm not going into details because it would take an entire presentation, but I just want to focus on stage 3, 4, and 5. Usually, which type of surgery is needed? If it's feasible, we should go for endoscopical drainage, but we have to be ready to perform also external approaches, especially in case of abscesses of the eyelid and the superior and lateral abscess of the orbital compartment. If the frontal sinus is involved in the creation of the inflammatory process, we should consider open approaches in case of multiple previous surgery, no endoscopic access, especially in case with the far lateral lesion inside the frontal sinus. So I want to present two different clinical cases. The first one is a 65-year-old female with right proboscis diplopia that was mildly responsive to antibiotic therapy. So we went for imaging. First we had with MRI, with the CT scan, and then MRI. And here we have an anterior ethmoidal mucocele. We can observe that the lamina papyracea was reabsorbed while the periorbit was intact. Here we can see this black line, and the mucocele is pushing on the orbit, causing proptosis. So we went for endoscopic drainage. Here we are entering the cavity with great satisfaction, removing all the pus. I'm gonna speed a little bit, and here we have this swab, very important to find the involved pathogen. And here we are enlarging our hole, and we are completing the face. And here we can see the periorbit that was completely exposed in this case. Next case, an opposite case. So a male with no major comorbidities with multiple mucoceles following endoscopic sinus surgery. So here we have a very lateral and superior mucocele inside the frontal and a very posterior mucocele inside the sphenoid bone. So this was a very challenging case, and we decided to go for a combined approach. I just want to show the approach for the sphenoidal lesion. And here we can see the incision on the eyebrow. We have to reach the superiostal plane. And here we are trying to find the plane, the superiostal plane. And we use some silastic, as we can see here, to create a good corridor for the endoscope. And now we start our endoscopic assisted procedure. So we continue our dissection, we continue posteriorly, we see that it's a very safe plane, and we reach posteriorly the cavity here, and we enter the cavity. Of course, we were using the neuronavigation to help us in finding the structures. And here we have the pus coming out from the cavity. We remove all the inflammatory material. We remove all the mucosa just to avoid problems with the healing process. So this was a very tricky case. So starting with the second topic, so orbital complications of endoscopic sinus surgery. Usually during standard endoscopic sinus surgery, no unexpected events should be expected, but sometimes we have to face unexpected complications. Especially at the level of the orbit, lesion of the lamina papyracea or periorbit, minor or major bleeding, ocular musculature injury, and optic nerve injury. The rate of orbital injury is not very high, usually less than 1%, but we have to consider the volume of the number of procedures we perform every year. So we have to be ready to face such an event. Of course, the risk of complication increases with the complexity of our approach, especially in case of multiple previous treatment, and in presence of lack of anatomical landmarks inside the nose, and this is increasing the rate of complications. Starting with the injury of the lamina papyracea or periorbit, of course, we can have the emphysema. Usually it's self-limiting, but we have to stress a lot the patient about not blowing the nose after surgery. It's not the situation is getting worse. And periorbital suffusion without swelling is usually treated with just observation and antibiotic therapy. Injury of the inferior rectus muscle and superior oblique muscle, a bad nightmare, of course, are less frequently damaged and are favored by the use of powered instrumentation. And usually the management of such a complication is on the ophthalmology. So the management is multidisciplinary. How to reduce, not completely avoid, but reduce the rate of complication. We have to check for the imaging preoperatively, and we have to check for reabsorption of the lamina papyracea, herniation or prolapse of the orbital content, dislocation of hypertrophy of the muscular, especially the medial rectus muscle, and we have to check for the position of the maxillary ostium in respect with the orbitomaxillary angle, and it is very important, especially in cases with sinus-sinus syndrome, in which we risk to go inside the orbit before entering the maxillary sinus. So now I'm connecting with the topic of Axel, and the ethmoidal artery laceration and stump retraction can give an orbital hematoma. This is quite an emergency because the patient risks to have very important postoperative sequelae, and we have to be ready to do many things. The first one is to, of course, try to cauterize endoscopically the bleeding point. We have to be ready to perform an orbital decompression from the nose and from with an external approach, lateral, and it's very important to be able to perform lateral cantotomy and inferior cantolysis. These two procedures are very simple and are very nice to be known. Of course, these are rare scenarios, so it's difficult to be ready to have a good training in the clinical practice. So once you have to be ready to perform it. So I suggest to practice in the cadaver lab before having surgery. And of course, if you cannot find the bleeding point, we have to be ready to perform a lynch approach inside the orbit and finding the stump of the ethmoidal artery, which is bleeding. We can have dramatic mechanic complications, or of course are extreme, but are described. So section of the optic nerves and eyeball nucleation. Of course, these are done using powered instrumentation blindly, let's say that. But we have also rare unpredictable complication, especially in terms of central retinal artery occlusion caused by fat embolism, and this is unpredictable. And also we can have the oculocardial reflex during endoscopic sinus surgery with cardiac arrest. So we need a good anesthesiology when we are performing this type of procedure. How another time to reduce our complication? We need a sound and multi-prospective anatomical knowledge. The cadaver lab is the ideal venue to build this knowledge. And we need a wise but not blind use of technology, and in particular as regards the neuronavigation. In difficult case, go for the neuronavigation. And also very, very important, we need for a prudent employment of power and instrumentation. And we have also be ready to stop when we are not comfortable with the anatomy. This procedure are usually performed for benign lesions, for benign pathology. So we have to be ready to stop when we are not safe and we are not feeling comfortable with the anatomy. And this happened also to experienced surgeons. So in conclusion, for the first part of the presentation, the conclusion are that we need for an early identification of signs and symptoms. The management of orbital complication is multidisciplinary, ophthalmologists, infectivologists, ENT. And we need for imaging with contrast enhancements to better highlight the inflammatory process. For the second part of the presentation, it's very important to have a multi-prospective anatomical knowledge. Another time I'm stressing it. We have to avoid the use of powered instrumentation if we are not completely safe with them. And we have to know, of course, how to manage complications. So thank you for the attention.
Thank you, Vittorio, for a great talk, which is very on the spot, really. And so now we will directly continue with the last talk, and discussion will follow afterwards. So Professor Meco will continue, and please.
Thank you very much, Paul. I'm so happy to hear the other presentations, perfect talks. Thank you very much for the kind invitation to this webinar. I'm very much honored. I'd like to thank the boards of ERS and Junior ERS for their kind invitation. So I'll just start with my presentation. Okay, so I'll be talking about the intracranial complications tonight as rhinology emergencies and what we can do as rhinologists or otorhinolaryngologists. I have nothing to disclose to mention, but only being the president of the Confederation, I would like to first invite all of you to the biggest event of this year in November, October 29th to November 2nd in Milano. The registrations are open, and we really have, together with Dr. Piero Nicolai and Isabel Villaseca, have made a perfect program for you to join. Also for the juniors, there is a special track for you. So when we talk about the complications, the intracranial complications, naturally, the meningitis is the most common that we see and encounter, but they can really go more further, like epidural abscess, subdural empyema, intracerebral abscess, encephalitis, but also superior sagittal sinus thrombosis, cavernous sinus thrombosis. And even though it is not an intracranial complication, we can also consider Pats-Paphier tumor, the subperiosteal abscess, also as a provider of the intracranial complications due to the valvulus diploic veins of the frontal bone, which provides a perfect pathway to the intracranial cavity from the frontal sinus. Thus, generally, we see those intracranial complications related to the frontal sinusitis. Okay, why it is not? Okay, this is naturally a multidisciplinary management. It requires a multidisciplinary management. And when we think about where is our place in that multidisciplinary management, of course, neurosurgical colleagues have an important position in the intracranial complications, but we can also play an important role by really guiding those patients to the neurosurgeons early on. But all these disciplines have their expertise and part to play in the state-of-the-art multidisciplinary management of intracranial complications. So what is our role as a rhinologist? Or actually all otorhinolaryngologists should be really having an idea about that, because this could be a really devastating disease by having very high mortalities. Almost 1 to 5 patients might be having some kind of, morbidity or even mortality. So first of all, we should be knowing how we can avoid, but we can really have to have some idea how to have a high index of suspicion and early detection, which could be really critical in the management. With that would bring the early consultation to radiologists and neurosurgical colleagues, and then of course we have a role as an active participation in the treatment. So how does it happen? Generally, it is due to this sinonasal cavity infection, so rhinosinusitis, and there are 2 different modalities that could cause an intracranial complication, which could be hematologically through the diploic veins that provide a passageway to the pathogens to reach the brain, or it could be a tissue continuity spread. So the pathogens can reach intracranial structures directly by erosion of thin bony sinus walls. But also we should be really thinking of the integrity of the dura mater, because these patients are also our patients, the CSF leak and dural lesion patients like meningocele, meningoencephalocele. So they can also come to us as having meningitis or brain abscess. So looking to the pathogens, it is generally an anaerobic or mixed aerobic anaerobic organisms, and there is generally a inflammation, a meningitis or encephalitis in the beginning, and which progresses to necrosis and liquefaction of the brain tissue with a reactive connective tissue capsule, as you can see here, forming around the brain abscess. So generally, the acute bacterial rhinosinusitis is the causative. Although it's a relatively common condition, it rarely causes, thanks God, to intracranial complications. And unfortunately, as like the orbital complications, after them, intracranial complications are mostly seen on the pediatric age group, but also in the immunocompromised patients are in risk. But still, the untreated or incompletely treated acute bacterial rhinosinusitis patients may also develop this, although they're immunocompetent. Another causative is the acute invasive fungal rhinosinusitis, which is completely a different team. they are generally immunocompromised patients, like having diabetes or lymphoreticular malignancies, HIV infection, chronic renal failure, or liver failure. And the management of this is completely also different. You require more aggressive surgery to treat. I would like to emphasize a point that, as you know from our EPOS 2020 paper, that actually the number of patients who require really an antibiotic therapy for acute bacterial rhinosinusitis is only a small portion. But if you really miss the ones who would really need it, so untreated or incompletely treated ones, they could develop these intracranial complications. So we should be always almost think about this issue also, because as you can see here, the intracranial complications can really happen up to, in some series, 38%, but generally around 10-15%. But the thing is that once they occur, they have a significant mortality up to almost 20%, and morbidity up to 45%. So it is really important to really catch those patients correctly, and actually through the care pathways written in the EPOS 2020 paper, those purple areas are to highlight this fact that if you have these alarm symptoms, the sign of sepsis, meningitis, and or neurological signs, we shouldn't really be losing any time, and immediate referral is important to save the lives of the patients. So regarding those symptoms, of course, they could be non-specific, as of a systemic inflammatory response like high fever, headache, lethargy, reduced consciousness, or they could be specific central nervous system signs due to focal neurologic damage or increased intracranial pressure, like nausea, vomiting, neck stiffness, altered mental states. But we should never forget that they could be also silent. And the subdural abscess generally emerges like an emergency case and comes with neurologic symptoms. But on the other hand, epidural abscess might be first diagnosed on the imaging studies. So it might have very subtle symptoms. But on the other side, the intracranial abscess generally show a sign of increased intracranial pressure, meningeal irritation, focal neurological deficits of cranial nerves, and severe progressive headache. But still, in some patients, it could be also symptomatic, but still subtle, affective, and behavioral changes are not uncommon. So how to proceed? We have to really have a high index of suspicion, be aware of neurologic symptoms. The synogenic intracranial complications may rapidly progress. So we should be really not losing time, especially in pediatric and immunocompromised patients. So thus, in order to make a triage of the patients, if we have a suspicion of the intracranial complications of rhinosinusitis, as an initial screening test, we can use the contrast-enhanced head CT, because it's generally most easily available one, and despite its limitations, it can really identify features that would immediately triage the patients for a neurosurgical management. And by using this as the initial screening, we can identify the significant mass effect, space-occupying brain lesions, large extraaxial collections, and hydrocephalus. And once contraindications are ruled out, we can have a lumbar puncture, which can safely be performed then to evaluate the meningitis while we're organizing the MRI, because MRI being the gold standard is important to evaluate the intracranial contents with greater sensitivity and specificity. But we should be really communicating with our radiologists right away. Why are we sending that patient? Because in those patients, not only the contrast, but also diffusion weighted seconds would be important, which delineates the infected collections, but also detects complicated infarcts, which could be the cause of the mortality. Treatment, it should be really as soon as possible, as the multidisciplinary fashion. Naturally, our neurosurgical colleagues are the most important here, because they should do the neurosurgical drainage of the suppurative intracranial complication, except meningitis. It could be through a craniotomy, burr hole, image-guided aspiration, eliminating the collection, even if it is small. And we should be really doing the concomitant drainage of the sinuses, managing the source of infection. Most often frontal sinuses affected, and this could be even addressed by the endoscopic management. Then, of course, the corresponding medical treatment is very important. It should be aggressive with high dose, long-term IV antibiotics directed by culture and sensitivity. So as you can see, the mortalities are pretty high, almost reaching to 1 of every 5 patients who are affected. And I'd like to give two case samples, with one with a subdural MPM of a 14-year-old female who came to us with fever, confusion, aphasia, tendency for sleep, and right hemiparesis that has been ongoing for almost 2 days. She had been diagnosed with acute bacterial rhinosinusitis 5 days earlier, and then using second-generation cephalosporins. Here you can see the one-sided acute bacterial rhinosinusitis findings, but here you can appreciate the thick subdural empyema, which also causes a shift to the right. So it has been managed in a multidisciplinary fashion with our neurosurgical colleagues, with a temporoparietal craniotomy, but we are also doing the endoscopic drainage, and all these symptoms have resolved, and this is the postoperative 1-year imaging. So we were able to save the patient. And the second is again a subdural empyema of a 12-year-old female. As you can see here, she came to us with a confusion and tendency for sleep. Had also been diagnosed for acute bacterial rhinosinusitis 2 weeks earlier, and having already antibiotics, but you can see the collections, and this was the intraoperative situs with pus coming after the craniotomy has been done, and this is the postoperative MRI of the same patient. So I will actually stop here. I also had some slides for the CSF leaks and dural lesions, but this is also an important topic, as we should be aware that the patients with having CSF leaks and dural lesions, even if there is no active CSF leak, can really present with recurrent meningitis attacks, and then could have also brain abscess, and it is very important to really diagnose these patients and treat and surgically close their CSF leaks. So thank you very much, Pavel. I guess there are, I guess I've just finished my 15 minutes, so I'll not continue with those slides. I'm sure that there are questions for us coming.
So thank you so much for this presentation. Perfect, excellent. I would like to ask a question first, if I may. And there is a lot of discussion about whether to open the sinuses when there is an intracranial complication. If so, what are the indications? Let's say, for example, you will have a patient who is a 4-year-old child. There is uncomplicated acute rhinosinusitis with a frontotemporal collection, so not adjacent. And there is a bit of thickening within the frontal sinus, and let's say subtotal opacification on the contralateral maxillary sinus. Would you, in such a case, for example, treat the patients with the surgically sinuses, not the collection?
Well, I mean, I can continue as I have been speaking on that topic. There is no question for, even if it is very small, for the intracranial collection. So, and it could really make sense to open up the sinuses even in that 4-year-old kid, because we really need to get rid of the further causative of the infection. Because there's enough evidence also written in the EPOS 2020 paper, but also, I mean, that's a very nice collection of all literature up to now, that if you do not really address the problem at the sinuses, those patients do get continuous craniotomies. So, I mean, and each time that there is a new collection, as I have shown and mentioned, 1 of every 5 have the chance of mortality. So, I mean, even if, I mean, in a 4-year-old kid, there would be not that much big sinuses anyway. So the onset process will be bigger than the adults. So it will be hypertrophic. Naturally, it's a very, very small cavity, but and in an infective area, it is naturally not that easy to proceed, perhaps, you know, small, and it will be bleeding a little bit because of the infection, but it makes really sense to open up and drain those sinuses. It's a different topic. I don't know if there is no evidence of any collection on the sinuses, but if you see something, it makes sense. I mean, the evidence up to now actually tells us that we should be really going. But I don't know what Axel and Vittorio are thinking about that.
Yeah, yes, I think I'm totally with you. I think you should set the indication generously in these cases, because it's also not a big thing to open the sinuses. And if there is anything suspected like that, then you can go for it, because the risk is not as high as persistent or recurrent intracranial abscesses. So we used to, it must not be it doesn't have to be an emergency indication, but at the end we try to be generously, or I would try to be generously with the indication and go for it if there is any sign for that. But of course you have to decide on the individual case, but I also would recommend in doubt to open the sinuses, just to be sure.
Yeah, and I completely agree, because I think that in cases in which you are not sure that the sinus problem is causing the intracranial problem, you have to solve every potential cause of infection. So even in case, for instance, the case of Pavel, of the contralateral maxillary sinus and so on, I would go for surgery just to remove every potential origin of the infection, even if the odds of the origin it's not so high.
Thank you. That is actually because this is, I think, the problem in all around the world, that evidence is at level 4. There is not really any proper data. These case controls are not necessarily matched, so it's a bit of a problem, and I think the protocols really vary. So we would tend to actually start with the antibiotic treatment in for example, such a patient, but it's very difficult to say if this is correct or it's not. So thank you very much for sharing your experience. And now we have got another question from our colleague Domen, who is asking if you would when do you decide to perform endoscopic sinus drainage in the intubated patient on the ICU in the full sinuses and sepsis? Sometimes infectologists cannot establish the origin of infection. So the patient has got sepsis, is intubated. It sounds like there is a problem, is only the acute rhinosinusitis. We don't know where the sepsis is coming from. And without any other complication, I understand, would you drain the sinuses, or would you just continue with the antibiotic treatments? I assume this is incidental finding, or it's a patient, basically we don't know what's the reason for the sepsis. Vittorio, how would you?
Yeah, I think it depends on the stability of the patient. It's if the patient is intubated but relatively stable, you can go for surgery. If it's incidental and the patient is very unstable, maybe I would wait a little bit. But it depends on the patient, I think.
Any Chen, would you do anything?
Yeah. Actually, I mean, in the ICU, that sepsis patient would be really also having, you know, the antibiotics that the normal rhinosinusitis patients would not really having. So it will be really very broad band, and that also I would assume. I mean, not only the stability of the patient, but how long the patient have been there. That would also have a negative effect on the sinuses, on the drainage. The thing is that we should think, what will this procedure additionally bring? So it might be also helpful sometimes that through this procedure we can get some sample that we can guide the antibiotic therapy better. So this is really, again, a very multidisciplinary decision that has to be made. The anesthesiologist, the intensive care specialist, and the clinical infection disease doctors, and we really need to. I mean, it's not a general decision, so it should be really made per case.
So, if I may, at guys, we would actually follow Professor Stamberger's recommendations. Also for the intracranial collections, very often we would just decongest, especially when the patient is intubated with a xylometazoline adrenal in the osteomeatal complex. Patiently wait for 20 minutes with the neuropathies without any damage to the structures. To be honest, in these uncomplicated acute rhinosinusitis, just suddenly hoops, and all the pus comes out. We take a sample, and this is what we actually do also for the intracranial collections very often. Axel, you should probably be the one who wants to confirm.
Yeah. I think you have to decide individual sinusitis. Mainly the probe, the samples, and the swabs are the major interest in these patients, because the surgery itself, there's the question if the problem will be a solution for the problem, or if it's the sample itself that we have to send to our infectiologist. So I'm with you to mainly focus on the samples, and thereafter to decide if the surgery itself helps the patient in regard if potential complications again.
And then I would like to ask from the audience. We don't have any other questions, so I would probably just maybe finish it with one more question. There is a lot of talk in the ENT community about stopping, for example, anterior ethmoidal artery bleeding using the Lynch incision, as Vittorio mentioned. And you also I've seen that you show the eyebrow incision. How do you feel about, because the oculoplastics, they are slightly different, they live in a different world. They would always do transcaruncular instead of the Lynch. They would do trans upper eyelid approach instead of eyebrow. And the Lynch in the eyes of oculoplastics is becoming fairly obsolete. Obviously, in ENT is a different world. So how would you, are you maybe switching towards these less invasive approaches or not much?
Actually, I have to be honest, the only case I saw in which this was necessary, it was an emergency case. And I think that the Lynch approach in that case was the most direct way to go in. Probably could be your point. It's good. I think that I have the experience of this emergency case, and the Lynch was the direct view, the direct.
99% of ENT would do so. That's why I'm asking about your experience, because. And
also about the eyebrow, superior eyelid, of course, it's less invasive, but another time, if you need to go for emergency cases, maybe the eyebrow is faster than the superior eyelid, so I would go for that.
Would you have any maybe comments on that? Or Cem, would you?
Well, I mean, I've made throughout my residency a lot of Lynch incisions. I mean, I'm a little bit older.
Yeah, we all still do.
So I mean, and that was actually the mainstream approach for us for many of the problems that we are dealing right now through the endonasal endoscopic way. So even for all ethmoidal CSF leaks, for example, that was our approach, and not only for hemorrhagic complications, but it all depends. If I have the sinuses already open, or even if not, when just doing an anterior ethmoid, I mean, it's really time sensitive, as Vittorio says. So, of course, if it is a time issue, and if you don't have your endoscopic setup at that moment, Lynch incision, you go there, it's very, very fast, very, very fast. Yeah. I mean, endoscopically nowadays, I think I can also reach anterior ethmoidal artery as fast as perhaps I can reach by the Lynch incision, because they all, I mean, you again need to do some setup for that. The only problem, as you both have shown, that if the patient is already out of the OR and have some kind of intraorbital hemorrhage, so this is what you have already shown how we deal with that. This is all different. So I mean, it all depends again according to the specific case and time, and there is no correct answer for that.
So
how you feel comfortable is also important with each approach. So I mean, the one that you feel you're better, you're faster there.
That's very correct. We had actually one case of a bit of a catastrophe where the surgeon, his answer why performed endoscopic approach not successfully in orbital complication, which resulted in a vision loss, was that the residents wanted to see the endoscopic approach, and he wasn't a rhinology specialist. So I think it's important not to be a hero and to do whatever is effective to save the vision and to save the eye and to prevent anything major happening. So yeah, that I absolutely agree with. Thank you very much. I would like to thank the panelists for the fantastic talks and discussion. I think we are reaching the end of the webinar today. I would like to thank also the European Rhinologic Society for the fantastic support, and lastly, Olympus. Thank you very much.
Thank you. Thank you.
Thank you very much for the kind invitation.
Thank you.
very much.
Looking forward
Thank you.
to see all of you in Milano this year.
Of course.
Absolutely.
Bye-bye.
Bye-bye.
Bye. Bye.